last year we organized a conference like this one. We call it Global Health Conference, and students from different countries presented. This year we tried to be more specific and have more specific theme. So we thought a theme which can come across all countries, which is the healthcare and inequality. The inspiration for this conference and future conferences come from you, the students who are here. I'm so grateful for our members of staff also who's here. I know how busy all of us are, but I'm so delighted that we all put the time to come here and discuss. I want you to challenge all the presenters, myself included. I want you to talk, I want you to ask questions, I want you to create a debate, because that's what the whole idea from today is. Last year, when we organized this conference, some of my colleagues were laughing. They said, students don't come. They're not interested in things like that. Forget it, you're wasting your time. I said, let's try, even if 10 of them come, it's okay, it's fine, we can make a conference. And last year we have 75 people coming and 87 registered. There's always 10% drop. This year we have 111 people registered, and I counted for 10% drop. So hopefully we have over 90 people attending today. And that's great. If that tells us anything, that tells us there's a need for that. So once again, thank you very much for coming. Without any further notice, our time is over. And I'm very, very pleased to introduce my colleague, Yanis. Yanis,
sometimes we'll make the mistake to look at our research as a project. And what I usually say to my students is that this is not a project, this is research. And what is the difference between a project and a research? A project could be something that PricewaterhouseCoopers could actually pay you to do, or McKinsey pay you to do, or the NHS pay you to do, and you take the money and you deliver. That's a project. Now, a PhD, for example, and some of you, I can see some faces in here, some familiar faces, we have heard this a lot this year, is that what you're trying to do, and I usually ask my students, so what do you need in order to do research? And everybody says, what is the answer to that? A research money, said somebody. Yes, that's right. And you also need a research question, right? And everybody says, a research question, research question. I said, yes, but in order to have a research question, what do you need? And you usually need what, guys? You need a problem. If you're not solving a problem, there's no reason to spend 4 years of your lives doing research. And once you do the problem, once you understand what the problem is, you have a research question, yes, but then you also need to make an impact. So if you spend 4 years of your lives doing a PhD, or 3-4 years of your lives, getting money, do research, and you don't present an impact to the society, to the patients, to the economy, then I don't think you should spend those 4 years of your life doing that. Now, the research is what links the problem with the impact. It's not just a piece of work that you got money to deliver a project. It's not just a piece of work that you got some funding from your government to deliver a project and some outcomes. You need to know what the problem is, what you're solving.
Bangladesh is a country where nearly 1/3 of its total population lies below the poverty line, and 50% people share only 20% of the total income. A wide disparity in utilization of healthcare facilities is also a characteristic feature of the country, and this is particularly prominent among the poor and marginalized. BRAC, formerly Bangladesh Rural Advancement Committee, founded by Sir Fazli Hasan Abed in 1972, soon after the independence, has now been appeared as the largest non-profit organization of the world and currently working in 11 countries of the world, including Bangladesh. Through multifaceted development initiatives, BRAC is creating opportunities for the poor and marginalized. It is trying to ensure an equitable access to all possible development initiatives such as education, health, and credit for the poor and marginal people to achieve sustainable development. BRAC is especially pioneer in addressing the health disparities of the country through offering fundamental healthcare services to the doorsteps of the destitute. According to the recent Lancet series, which is published on Bangladesh health situation, and Dr. Mushtaq Raza Chaudhary, Vice Chairperson of BRAC, is a prime contributor of it, also showed a significant improvement in health status over the years and affirms the noteworthy roles of BRAC in attaining these positive change. BRAC's flagship health program was Oral Therapy Extension Program, or OTEP, launched in 80s, reached about 13 million households, and was life-saving initiative for a huge number of diarrhea-affected patients. In Utep, a small army of dedicated community health workers approached millions of household women and educated them about the preparation of homemade oral saline made of salt and unrefined local sugar, locally known as Labungur Sharbat, to combat diarrhea. UTEP program was extremely successful in addressing diarrhea problem of the country, and that was also a learning experience for Bragg, which guided Bragg to establish an effective health system by which an equitable health services can be ensured for the poor and marginalized.
Think about social determinants of health if you're really going to make a difference to health, because all too often we focus too much on the service. So we say we need more hospitals, we need more beds, we need more of this. Well, actually, in most good healthcare systems and countries where they have high rates of life expectancy, it's the social determinants of health: education, access to jobs, access to healthy diets, access to exercise facilities. They're the things that really make a difference. I always recommend go to Cuba. It's really, really interesting to see what Cuba have achieved. And that's because they've really focused on primary care and public health. And that's because they don't have the money to have these huge super duper hospitals with high tech equipment. So they've really focused on trying to keep people disease free. And in Luton, what is it that sort of stays with people? So it's diabetes, cardiovascular disease, and these are mainly attributed to smoking and diet. And there's huge inequalities in this town. And we have to remember that over 50% of children in this town are non-white. So projecting forward, take this forward now for the next 10 years, we're going to have a very different population in this town compared to what it was at the current stage and what it was 10 years ago. And I don't know if anybody's familiar with school years, but year 6 means, I'm going to get this wrong, aren't I? 11-year-olds, I think. So at the moment, 1 in 5 children in this town are obese by the time they're 11, right? That's not good, in case you're wondering. That's just not good. All right?
And you are the privileged ones, aren't you? Because you're not in a primary school here. You're having higher education. And wow, and then with that knowledge and with that confidence, you will go back or wherever you are staying, living, working, and make a difference. And you will struggle to make that difference. But you will still have much more confidence than if you've never been to school. How would you possibly know what to do if you've never been to school? And 57 million children are not learning. I mean, that is shocking beyond belief, because what can we expect then if they've never been to school? Can we expect them to be rational, thinking citizens as they grow up, wanting to share nice thoughts with the rest of the world? I believe somebody else will want to give them an education that isn't about us all living and enjoying each other's company and sharing each other's culture. I think it's a recipe for disaster right around the world if this doesn't happen. And I so want you as a group, if out of this conference so many things will come out that might seem much more relevant to you, but I say if those little children of Syria, look at Syria, some of them were in school and now they're in a refugee camp. And
if I'm in Ireland, I don't tend to think of myself as Irish. Yeah? In Ireland, we have St. Patrick's Day. And we always say you can spot the people who are not Irish on St. Patrick's Day because they are the ones who are dressed up the most, being Irish. Yeah? If you are Irish, you don't have to be Irish. Until you're taken out of Ireland and you put in a context, we'll say like here, where I don't have very many Irish people around me, so the fact that I'm Irish is much more apparent to me. Yeah? So sometimes I don't act like Niamh the individual, I act as Niamh the Irish person. Yeah? It's the same for all of us, no matter what groups they are. If that group is important to you, sometimes you see the world through that lens. You see the world as a group member, not as an individual. And we have to take that into account when we look at health. So we're neglecting those kind of group notions, we're neglecting the social context. So when we talk about how does this apply to health services, okay, what we notice when we look at health outcomes and we do needs assessments like Gert was talking about this morning, we notice that there are different risks, or different populations are different risks, there are different health outcomes for different groups. People don't use services, but we find that when people get into services and start using services, everyone has a good outcome. Okay? The thing that's different is that the experience of being within the service varies depending on what group you're in. Okay? So everyone might have a good health outcome, but their experience of the service may be poor. Everyone has problems getting into mental health services, especially when you're at the secondary level. Okay, not so much primary care, but when you get into the secondary level. And what happens is that everyone can't get in, right? But it's only, of those who do get in, it's only the non-white groups or the black and minority ethnic groups that report higher levels of dissatisfaction, lower levels of trust in those institutions. So we need to figure out, well, why is that? Why is it not only we're having different health outcomes across different groups, but also different experiences?
Why obesity is concerned in Libya? Well, actually there is many reasons. First, Libya has undergone the nutrition transition due to, since the discovery of oil in Libya, so the shape of the disease has been changed. So the prevalence of obesity has been increased more than double over the 3 years, over the 3 last decade. Also, at the same time, the prevalence of obesity, of diabetes has increased, and Libya has the highest diabetes, not only in Arab region, but also in the North African countries. Libya has spent lots of money in order to treat the disease caused by obesity. It's estimated 1.2 million just as a direct treatment of the disease. But it's not estimated how is the other thing related to the indirect complication of obesity. For example, is absence from work or retirement or mortality rate. Also, Libya has been ranked in 2010 as the 35th fattest countries in the world. Either the non-communicable disease actually in Libya is the main reason for leading to death, and the percentage, just to show you in the next slide, which is how figure for each disease leading to the percentage. So it's higher than in any Arab countries, is 78%.
So I'm doing a mixed method case study to identify and explain factors that contribute to low birth weight and infant mortality in the Pakistani and Bangladeshi women living in Luton. There are ethnic inequalities evident in maternal pregnancy in Pakistani and Bangladeshi women living in the UK. So the picture for England is such that Pakistani women have a high perinatal mortality rate of 53 deaths per 1,000 live births compared to white British women who have a figure of 23.3. Bangladeshi women have the lowest average birth weight infants, and research has shown that South Asians are 2.5 times more likely to have a low birth weight baby, which is typically 300 grams lighter than white British women. And this has been shown to be pervasive across generations, so it doesn't matter how long they've actually been living in the UK. And it also, they found that the low birth weight doesn't always equate to poor health outcomes. Sometimes there's small babies, but they're perfectly healthy. Pakistani women have an infant mortality rate which is high at 7.6 per 1,000 live births compared to the English average of 4.2, and Bangladeshi women have a preterm birth rate of 7.9 compared to the English average of 7.2. So the picture for Luton is that we have a diverse population in Luton, with 21.1% of the population being Pakistani or Bangladeshi. It ranks 69th out of 326 on the deprivation scale. So, I mean, we know that Luton's a deprived area, and nearly 25% are Muslim.
The title of my poster presentation an examination of policy, surface supervision, and public knowledge factors associated with the prevalence of hepatitis B and C infection in the south of Libya. Let us start by looking at background. There are several causes of chronic liver disease. One of these causes is infection with hepatitis. There are many types of hepatitis, and the most important types are hepatitis B and hepatitis C, and the most severe one is hepatitis C. The previous study showed that the infection with hepatitis associated with the severity of chronic liver disease. Co-infection with hepatitis B and hepatitis B and hepatitis C also associated with the rapid development of chronic liver disease, as well as the co-infection with hepatitis B, C, and HIV has a role in progression to chronic liver disease. Therefore, looking at these types of infection is an important issue for this project. What does it mean, hepatitis? Hepatitis is an inflammation of liver caused in several ways. Hepatitis B virus and hepatitis C virus both transmitted through blood-to-blood contact or with other body fluids, and the most commonly they spread through intravenous drug use or through surgical procedures. If we can say here some statistical I have learned in my research. According to WHO, more than 240 million people globally are affected by affected by liver disease. Among them, 600,000 people die every year due to.
We're going to look at the historical perspective of this disease. It's over time it's been associated with a lot of stigma. In the past, people with leprosy have been deemed to be cursed by the gods, and most times they've been isolated and taken into leper colonies where they're isolated from the people far from cities, and that has affected the perspective people have about this disease. Even in certain places where they are allowed to stay within the communities, they attached bells and certain forms of identification so people could avoid them whenever they see them. And unfortunately, certain very influential people in the past have been affected by this disease. Okay. Grossly, the incidence of leprosy is underreported all over the world. And the World Health Organization states that there's one case every 2 minutes. But globally, the incidence is said to have reduced globally. But in certain parts of the world, the incidence is not known, and it could be even increasing more than we know because people are not reporting that they have this disease. And it's common among poor people and the uneducated. With early diagnosis, it is said that 5% still end up with disabilities. And since the diagnosis is basically clinical, it means the disease must have manifested in some forms of ways before it's been detected. That's what causes this 5% ending up with certain disabilities. Okay, treatment fortunately is free, and the World Health Organization has sponsored programs around the world to make sure that every individual that has been diagnosed with leprosy gets treated for free.
Now, because of globalization, the developed world, or first world countries, as we call them sometimes, are gravely concerned with healthcare in poorer countries and want us all to live a long and healthy life. You'll see a lot of commercials, international donor organizations encouraging people to support work in maybe Latin America and the Caribbean. You might see commercials especially talking about supporting vulnerable people in the African region. I'm sure many of you are familiar with some of those messages. There's also a very strong financial benefit to people being happy and people being healthy. It increases the likelihood of development through tourism, when we consider globalization in particular. It increases the ability for exchange of human resources, and healthy and happy people are able to work longer and produce more. And healthy and happy people who are able to work longer and produce more are also able to make more money. And if you can make more money, you can buy more stuff. So globalization and capitalization go hand in hand. And it's on the social responsibility. First world countries who have more feel the social responsibility that contributes to international and global development. In recent years, the culture of donor organizations have grown to include human rights, and we'll talk a little bit about that. Is there anyone here from a country in particular that you have noticed that there is an increase in a human rights emphasis in your country, or a push from external funders or external countries to push human rights agenda? Can anyone speak to that, have an experience that speaks to that reality?